Uh, Good evening, friends. Today this 9:05, and we have waited for other people to join. Today we'll go to the next part of the basics in ECG class. We'll look into the ventricular hypertrophy, left ventricular hypertrophy and right ventricular hypertrophy. So what is ventricular hypertrophy means in ECG? So a simple increase in the mass of the left ventricle, which can be secondary to the increase in the wall thickness or increase in cavity size. So it means that increase in wall thickness means this systolic overload. Increase in cavity size means diastolic overload. Simple. One is for almost a prototype of systolic overload, hypertension, aortic stenosis. The other one is where you have a diastolic overload, aortic regurgitation is the prototype. So that's the reason why you could define this LVH by increase in the mass of the ventricle with relation to the secondary to increase in wall thickness and increase in cavity size or both. So for understanding this LVH, we have to understand, again, go to the basics, transition. So from here, I'll try and annotate. So this is the left ventricle. This is the V1. This is the apex. This is V4. V5. Right, this is how it will be like this in the left ventricle. So whenever there is going to be any electrical activity towards the electrode, it is positive. Away from the electrode is negative. The basic is right, but your bundle of his divides into right bundle and left bundle. Left bundle being the dominant, left ventricle being the dominant ventricle. The first innervation is left to right. And then the rest of the ventricles are getting innervated. This is how it will be. Because the first innervation is left to right, V1 is sitting closer to it. So the first deflection is positive, and the V5, the next subsequent bigger deflection is negative because the whole wall thickness is very much away from V1 and also is negative. So that is the reason there is a big negative S wave. Whereas in V5, V6, you are having the first deflection is away from V5. V5 is here, first deflection away from V5. So it is the first negative septal Q wave. And the subsequent, with the increase in the throughout the left ventricle, endocardium to epicardium, the electricity travels, and the height of the R wave depends on the thickness of the ventricle or the cavity of the ventricle. So the V5 height of R wave or the depth of S wave depends upon the V5, V6 thickness of the ventricle. So V5 here, it is your electrical activity is being recorded from this area. It is closer to the electrode. So it is recording towards the electrode positive. Closer to the electrode, height is very high. Thickness, when it is thicker, it is much more thicker. Larger R waves are there. Similarly, the S wave will be opposite to what is happening in V5, V6. This is the basic. You should never forget the basic. Once this basic is there, then we will know. So now you will come to the left ventricular hypertrophy. When the thickness is much more, that is the first component is the septal activation. The second component is the ventricular activation. When the ventricular activation, free wall activation, when the free wall is much thicker, it takes a longer time to travel. It means the height of R wave in V5, V6 is going to be higher. So that is the reason why we are looking into two things, systolic overload and diastolic overload and the height of R wave in each of this. Whenever there is going to be a systolic overload, there is a resistance to LV systolic outflow. It could be due to aortic stenosis or commonly systemic hypertension. Whereas in diastolic overload, predominantly what we see here is your aortic regurgitation and in some congenital heart disease. So what are the abnormalities in a left ventricular hypertrophy ECG? See, there could be abnormality of the QRS complex. You start with the QRS complex. Abnormality of the ST and T wave. Axis also can become abnormal. And left atrial secondary dilatation can happen there. And rarely U wave abnormality can be there. Predominantly, left atrial and P wave will be there. QRS complex will be there. Affection will be there. STT changes will be there. And the axis can go wrong. So we'll see one by one. So what will happen to the QRS complex? See, now I clearly told you, towards the QR electrode, any electrical activity, it is always positive. Away from the electrode, always negative. These are basics. And very close to the electrode, it senses very tall. So height will be there. When the duration increases, when the thickness is more, duration of the R wave increases. So we'll see why one by one. So when it increases and completely travels here, take a longer time to innervate the whole ventricle, it means that the height of R wave will be increase in the magnitude of QRS complex deflection. Height of R wave will be larger. So the increase in the total QRS duration, it takes longer time because it is thickened. Height is increased. It takes longer time to go to the peak. So this is called this ventricular activation time. Increase in VAT. It means simple. It doesn't take a sharp upward. It takes a longer time to go to the peak. It is a ventricular activation time. And when it is, the free wall is dominant, there may be attenuation of the Q wave as well. In septal Q wave may be there. So this is what happens in a left ventricular hypertrophy. See here septal Q wave. There is a QRS complex upright. It is not taller. And when it comes to the J point, here there is STT segment. Whereas here, there might be, not every time, attenuation of the QRS Q wave in V5, V6, height of R wave increases, ventricular activation time increases, and there is going to, because there is a duration of the QRS complex and the longevity with which it happens increases, you are going to have secondary STT change. It's not primary, secondary STT changes. Whether either it is like a bundle branch block or a hypertrophy, you have secondary STT change. Last class we saw. So secondary STT changes will be there. ST depression. Here the ST segment, you look into it, it is convexity upwards. It is not concavity, convexity upwards with a T wave inversion. This is what happens in a systolic overload. What will happen to the ST segment and T wave? Abnormality of the ST segment is T wave will be inverted. Secondary STT change will be there. Importantly, it is not symmetrical. Asymmetrical, shallow proximal limb. See, this is what is important. Symmetrical T wave, I always tell you, it is ischemic. Whereas the asymmetrical T wave is not ischemic. So it is secondary to STT changes. ST segment minimally depressed. So ST segment depression with T inversion with slight upward convexity. It is not concavity, it is upward convexity. So every word is important. Upward convexity is there and it can cause secondary STT changes. Now you understand QRS complex height of R wave is there increased, ventricular activation time is increased, and secondary STT changes are there. ST segment depression with T inversion is there. What happened to the axis? Once the left ventricle is the dominant ventricle and it tries to pull the electrical forces towards the left side. So it means normally from the SA node to the AV node, it is conducting downwards and it axis is between 30 and 90 means. Here, if we have a systolic overload, all the forces are directed leftward and the axis can be leftward. It will be 0, -10, -15 likewise. So this is what happens to the QRS complex axis and the T wave secondary STT changes. Because of that, the T wave will be opposite to the QRS complex axis. Rarely you will have abnormalities of the U wave. It is not a common form. Rarely you will have abnormality of U wave. Left atrial enlargement is secondary to the left ventricular hypertrophy. A chronic hypertrophy means left atrium is finding difficult to fill the left ventricle. It becomes enlarged and you will have a left atrial enlargement. How do you say a left atrial enlargement? You are having a bifid complex in P wave in lead to width of the QRS complex. P wave is more than 2.5 small squares, or a terminal negativity with more than 1 millimeter deep and 1 millimeter width in V1. That's simple to remember the left atrial enlargement. If it is there, we can understand that it is secondary to left ventricular hypertrophy. So having known how to look into it, we will see the ECG. See here, the first thing is left atrial enlargement. P wave, terminal negativity, P wave is there. The P wave in lead 2 is slightly widened. It's not classic, but slightly widened. And the height of R wave, see here, very tall R wave, whereas in wave S1, at very deep S wave. So this is what happens. And there is a ST depression, convexity upwards, and a T wave inversion. So typically, this is a left ventricular hypertrophy. Increase in the ventricular activation time. It is not sharp, it is slanting. Ventricular activation time is increased. Height of R wave is increased. Secondary STT changes are there. ST segment is depressed with convexity upwards, and T inversion happens. Left atrial enlargement. All suggest the patient has got a left ventricular hypertrophy. It is simple because the left ventricle takes a longer time. Electric activity takes a longer time to traverse through the thickened ventricle. The QRS T wave axis, early stage, when there is no much of hypertrophy, no change. But late stage, more thickening the left ventricle, more likely there is going to be left axis deviation. And also because it is thickened, it is stretching. The left anterior hemiblock can also happen, where the degree of left axis is much larger to more than minus 30 degree. So is there any scoring system? So this is simple. Whatever that I told in the ECG is very simple. But if you want more accurate, increase in the QRS magnitude, 3 points. ST segment T, second STT changes, 3 points. Left atrial enlargement, 3 points. If there is additional left axis deviation, 2 points. Increase in the ventricular activation, 1 point. The same thing, whatever we are told. More than 5 points or equal to 5 points itself is called left ventricular hypertrophy. The last ECG we saw almost everything was there. So more than 10 was there. So this is what the Romhilt and Estes point scoring system for left ventricular hypertrophy. And to make much more easier, Sakalolean is our friend. So it is only simple. S1 in V1 and R wave in V5, V6, more than 35 millimeter. See here in this ECG, 1, 2, 3, 4, 5. So here itself, more than 25, yes. And R wave in V5, V6, more than 25. It is 50 millimeter. So here, more than 35 millimeter itself, we call it as LVH. That in the ECG, it was 50 millimeter. So now you know how to calculate a LVH. So see here, LVH, tall R in V5, V6 and deep S in V1. If it is more than 35 millimeter, we call it as LVH. So total QRS duration, it is much more compulsory. You have to add everything. More than 175, you need not. That is the other criteria are much easier. The coronal voltage criteria, another criteria is there. So V3S, depth of S and height of R wave AVL, more than 28 millimeter in male and more than 20 millimeter female, we call it as. So this is very difficult. We cannot remember every criteria, but this is going to be slightly difficult. So it is another way of doing it is only in R wave, more than 11 millimeter, we call it as LVH. See, now it becomes easier. Left atrial enlargement, height of R wave increases, ventricular activation time increases, secondary STT changes, and T inversion. You have got Romhilt and Estes criteria. You are through with your LVH. So the other criteria, your Sakalolean is our friend. So it is very simple. I add the S wave in V1 and R wave in V5, V6 more than 35 millimeter. It is LVH. Your R wave in AVL more than 11 millimeter, single criteria. It is LVH. So these are all simple criteria to assess where LVH is there. So diastolic overload. These are all things which is present in systolic overload. Is there any difference in diastolic overload? See, the tall R wave will be there, whether it is systole or diastole, because it travels through a longer distance. So the tall R wave will be there. A deep here, there was an attenuation of Q wave, subtle Q wave. Here, there will be a deep prominent Q wave, narrow Q waves in V5, V6. And relatively a symmetrical tall T wave, but it is upright. Because the T wave is upright, you find inverted U waves. Minimal ST segment elevation may be there. So see here the normal and diastolic overload. It is not a common ECG which we find because the diastolic overload is uncommon because severe AR is not isolated. Most of the time it is associated with some other abnormality. So we are not seeing it frequently. But this is a normal where septal Q wave is present. Here the septal Q wave is prominent, but only difference is the width of the Q wave is not more than 1 millimeter. It is only deep. It is not wider. So that is not pathological. It is not a infarct related Q wave. It is only deep, narrow Q wave and a slight appearance of ST elevation. And there is going to be a concavity upwards and a T wave, upright T wave. So this is what you find in a diastolic overload. The other features will be there. Height of R wave will be higher there. You can have some, you can have left atrial enlargement. What will be absent is in systolic overload, Q wave will be absent. Ventricular activation time will be larger because of the systolic pressure. Whereas here, deep Q wave, no VAT, ventricular activation time will be normal. Whereas tall R wave will be present. Upright T wave, ST segment and T wave. See the difference between diastolic and systolic overload. Common things are commoner. Hypertension is the common disease. So completely understand left ventricular hypertrophy in systolic overload. The clinical significance of the LVH. See here, you got differentiate LVH from a ischemia. See, any T inversion, ischemia should be ruled out. See here, the ischemia, there will be a symmetrical T wave inversion. This is the one difference. Whereas here, there is a asymmetrical T wave inversion, so which is not ischemic, whereas this symmetrical T inversion, most likely we are dealing with an ischemia. So always rule out ischemia in any disease, and ischemia is very important to be understood. So LV strain pattern, see here, asymmetrical, blunt, not very deep. Whereas ischemic T, symmetrical, pointed, and deep. So this is how you got to understand. Even in presence of LVH, you can find ischemia, where the T wave will be different from the secondary STT changes. So having known completely about left ventricular hypertrophy, we will see what is right ventricular hypertrophy. So right ventricular hypertrophy, your common is pulmonary hypertension with a mitral stenosis or a pulmonary stenosis, pulmonary hypertension of primary hypertension etiology. So these are the common causes. See here, the left ventricle appears normal, whereas the right ventricle takes a longer time because right ventricle is thickened. So the first activation is 1. The second activation, thickened right ventricle is also activated. And finally, the basal part of the right ventricle will be affected. So this will be activated. That is the final part. So accordingly, the ECG will change. You can see the right free wall activation. This will cause tall R wave, right free wall. Second activation, tall R wave in right precordial leads. Right paraseptal wall, tall R wave in RS complex in right, again right precordial leads. The final basal region activation will cause the RS complex in V1 to V6. Now I will show you. Abnormalities of the QRS complex, abnormalities of the ST segment, abnormality P wave. This is the same like your LVH, you have to look into the RVH as well. So what are the features of RVH? See here, we will start with the P wave. When there is a P wave is right ventricular hypertrophic happen, the P wave also can have, because of chronic pulmonary hypertension, P wave can also enlarge, and right atrium can enlarge and cause a tall P wave. It is more than 2.5 small square in ECG. Tall P wave will be there. Because there, and what will happen to the QRS complex? The RS complex will be in the V1 and V2 are the right-sided leads in case of precordial lead. So in the right-sided, predominant right-sided lead, instead of a small R and a big S, you will start having with the right ventricular hypertrophy, you will start having the tall R wave, RS complex, or a small R2 complex in left leads. So in the right side leads, you will have a RS complex. And increased ventricular activation time in V1, dominant R wave in right side leads. And because the right ventricle is the dominant ventricle, it is hypertrophy, there is a right axis deviation. That could be part of it. Right ventricular branch block can also happen. and the axis can be clockwise rotation. There will be a transition zone will be there earlier, as well as there will be an axis will be on the right side. We'll see from the ECG. I'll make it much more simpler. See here, normally there should be a RS complex, small r and a deep S. This is what should be there. See, normally this is what the ECG look like. This is what the ECG will look like. But what is happening is, instead of small r and a, you are not having anything. Straight away there is a tall R wave. So this tall R wave suggests that the right ventricle is hypertrophied and it is enlarged. Because it takes a longer time, tall R wave, there is always secondary STT changes. See here, secondary STT changes. The peak of R wave is not very, very steep. There is going to be a slight delay. Ventricular activation time may be increased. Height of R wave in V1, V2, V1, V2 predominantly can be taller, and there will be secondary STT changes can happen. Now you understand what it is there. So there will be a tall R wave, a secondary STT changes can be there. So what are the features? R wave will be tall. Generally, it's a minuscule R in V1 will be there. In case of right ventricular hypertrophy, you'll have in V1, R wave is more than 6 millimeter. See here, one criteria. Left ventricular hypertrophy, you've got a lot of criteria. Here in only one criteria, R wave tall more than 6 millimeter, height of R wave. Or a small q is there means we'll have a very tall R wave. So that is one criteria. The other one is R wave in V1, like your LVH, S wave in V5. If you add together, it is 10.5 millimeter. Whereas in LVH, it was 35 millimeter. R wave in V5 plus S wave in V1 was more than 35 millimeter. Whereas here, R wave in V1 plus S wave in V5, V6, or V6 is more than 10.5 millimeter. R is always larger than S in V1. So that is more than greater than 1, the ratio. Sometimes right bundle branch block may be there. Secondary STT changes may be there. Right atrial enlargement may be there. So if these are there, then we will call it as right ventricular hypertrophy. You can see here, abnormalities of the QRS complex. There will be tall R more than 6 millimeter, or height of R wave plus depth of S wave. See here, more than this plus S wave in V5, V6 is more than 10.5 millimeter. We call it as RVH. Right atrial enlargement in ECG, secondary STT changes, right axis deviation will all point to the patient having right ventricular hypertrophy. Abnormalities of P wave, a tall and peak P wave will be there in lead 2. It is more than 2.5 millimeter in height. Then we call it as right atrial enlargement. Abnormalities of the QRS complex, height of R wave will be more than 6 millimeter in V1, R by S ratio more than 1, R wave plus S wave in V1 and V6 more than 10.5 millimeter. Secondary STT changes, we call it as right ventricular hypertrophy. Now you are thorough with LVH and RVH. What will happen if there is going to be biventricular hypertrophy? Very rarely you can have it. So ECG of LVH associated with right axis deviation. LVH means it should be left axis deviation. RVH means it should be right axis deviation. Likewise, when there is RVH with left axis deviation, think about biventricular hypertrophy. LVH with right axis deviation, then you have to think about biventricular hypertrophy. It's simple things. And patient has both the atrial enlargement, think biventricular hypertrophy is also there. So these small additive clues will give you a suggestion of biventricular hypertrophy. Both height of R wave as well as depth of S wave in V3, V4 will be very much larger. So that kind of situation can be there in VSD with reversal Eisenmenger. What we call it is a catch vessel phenomenon where there is a biventricular hypertrophy. So this ECG is there, mean there is a suggestive biventricular height of R wave and height depth of S wave is equal to or more than in V1 and V6, means you are dealing with possible biventricular hypertrophy. Now you have known that how to diagnose left ventricular hypertrophy, how to diagnose right ventricular hypertrophy, how to diagnose biventricular hypertrophy. So with this, I'll complete the session. I'll stop sharing it. And if you have any doubt, you can always clarify and clear it. Everybody can unmute yourself and talk whatever you want. And if you have any doubt, I am ready to answer.
Sir, good evening, sir.
Sir, please, sir.
Dr. Damu from Kambam.
Please, sir.
Left ventricular hypertrophy, secondary STT changes. அப்போ வந்து இன்ஃபாக்ஷன் வரும்போது அந்த சேஞ்சஸ் மாறிடும்ல சார்?
சார் இன்ஃபாக்ஷன் வரப்ப எல்லாமே கொஞ்சம் மாறி வரும் சார். சார் சப்சிக்வெண்ட் கிளாஸஸ்ல வந்து நான் மோர் காம்ப்ளெக்ஸ் டீல் பண்ண ஆரம்பிக்கிறப்ப ஐ ஆட் ஒன் மோர் அடிஷனலா ஆட் பண்றேன். இப்போ இன்ஃபாக்ஷன் வர்றப்ப வந்து you will primarily deal with something else. If there is going to be already an infarction happened, you are dealing with only QRS complex. If there is going to be infarction happening with ongoing ischemia and infarction, STT changes will be there. Like your LBBB, where secondary STT changes, Carbosa criteria was there, where secondary STT changes will be replaced by a primary STT changes. Likewise, in LVH also, secondary STT changes will be replaced by a ST segment elevation or depth of it. ST, when there is secondary ST depression and T inversion is there, completely it will go off and there will be ST segment elevation will be happening. We will see as a normal ECG, sir.
Okay, so one more question, sir. This hypertrophy in the condition of hypertension, that same hypertrophy due to the hypertrophic obstructive cardiomyopathy or condition. ரெண்டே டிஃபரன்ஷியேட் பண்ணிர முடியுமா? ஒரே மாதிரி தான் இருக்குமா
சார்? ஹைப்பர்ட்ராபிக் கார்டியோமயோபதி நான் முன்னாடி கிளாஸ்ல நீங்க கவனிச்சிருந்தீங்கன்னா தெரிஞ்சிருக்கும். ஹைப்பர்ட்ராபிக் கார்டியோமயோபதி height of RV will be there same, but the QRS complex STT changes will be different, where you will have a more deeper ST segment will be there and the TV inversion will be more deeper, wider. So it will be a typical changes where you will have a deep T wave, wider T wave, as well as you will have a splintered complex in the QRS complex, where here in LVH you will have only a ventricular activation time will be increased, height of RV will be there, as well as you will have a secondary STT change where the ST segment is slightly depressed, as well as you will have a convexity upwards in the ST segment, asymmetricity of the ST segment, and a shallow T wave inversion. This is what the LVH, whereas in hypertrophic cardiomyopathy, you will have a ST segment will be curved, deep T wave inversion more than 10 millimeter, most 5 to 10 millimeter, whereas here in the ST segment, secondary STT change, you will have less than 5 millimeter. So everything is different, totally different from LVH and HCM, sir.
Thank you, sir. Thank you, sir.
Sir, good morning, sir.
Hi, Solupa.
Sir, சூப்பர் கிளாஸ் சார். சின்ன எனக்கு சந்தேகம் சார். சார் இப்போ எல்விஹெச்ல வந்து ட்ரெட்மில் பண்ணா பாசிட்டிவ்னு வருமா சார்?
இல்லைங்க, அது there are some criteria to say it. So whenever there is a baseline STT changes, very difficult to interpret the treadmill because you depend on ST segment depression in treadmill to say whether it is positive or negative. So already a pre-existing ST segment depression happening in an ECG over and above the ST segment. If it is 1 millimeter ST depression to start with, it should be another 1.5 to 2 millimeter more ST segment depression should happen in peak axis, then only we call it as positive.
Okay.
So it is very difficult to interpret in a rate of 130 or 140. So in LVH, if it is telling it is a positive treadmill is always going to be difficult. So you have to go with the symptom. You have to go with other findings, resting STT, symmetrical TV inversion, everything. In treadmill, LVH, you have to add more than 2 millimeter from the baseline ECG to start with.
Okay, sir. The false positive நிறைய
chance நிறைய இருக்கு.
Yes, sir. Okay, sir. Thank you, sir.
And the thickness of the ventricle also can have a supply demand mismatch and can without coronary artery disease also can have positive disease.
Yes, sir. Thank you, sir.
Sir, good evening, sir. Anita here, sir.
Madam, good evening, madam.
Sir, next class in the CAS what shall elaborate பண்ணுவீங்களா?
அதுல congenital heart cell heart disease வரப்ப elaborate பண்ணிட்டுமா மேடம், இல்லாட்டி நான் சொல்லிட்டுமா மேடம்?
ஏதோ ஒரு 2 லைன் சொல்லுங்க சார்.
இதோ இருங்க மேடம், நான் So I'll try and draw this, madam.
Yes, sir, please.
It is difficult to annotate. The computer is not cooperating. Just I'll annotate. Right. So you are having biventricular hypertrophy in ventricular septal defect. You
Yes,
are
sir.
having a defect here. Both the right ventricle and the left ventricular systolic pressure are equal. And
Yes,
in
sir.
case of Eisenmenger, both the diastolic pressure also will become equal.
Yes, sir.
That is the
Yes,
reason why wherever you put a catheter, it will be right ventricular pressure and the left ventricular pressure, both will be equal. Because there
Yes,
is
sir.
non-restrictive VST, both left ventricle, right ventricle, and hardly any sound. You will not have a murmur. You will be silent heart. This is the situation.
Yes, sir.
You will have a single S2 silent heart because both the A2 and P2 are going to happen at the same time. Single S2, single S1, biventricular hypertrophy. Okay, both systolic and diastolic pressure and all chambers will be equal. So what will happen?
Okay, sir.
Okay, see here. I am from bundle of script, right bundle, left bundle. Both are dividing, and the first activation left to right.
Okay.
So I am drawing the V1. But
Yes, sir.
because the right ventricular forces is much taller, the right ventricle is hypertrophy, the force drags it over here. So it becomes taller here.
Okay, sir.
From V1, you are looking into the negative force in the second activation here. Because it is much deeper, thicken ventricle, because the highest systolic pressure, it becomes deep. So V3, V4, where there is usually a transition, this will be very much height of R wave in V3, height, depth of S wave will V5, V6 will be like, because both the pressures are equal on both the chambers, it will be like V5 R and V1 S. So height of R wave will be like a V1, V5, and depth of S wave will be like a V1. So V3, V4 transition zone where you expect one to decrease, other to increase, it will not be there. It will be completely tall R wave and a deep S wave. This is the classic of VST with reversal, Eisenmenger, biventricular hypertrophy, where you are having a non-restricted VST. Both the systolic and diastolic pressure in both the ventricles are the same, and you will have clinically single S1, S2, and single S1, silent heart, no murmur, LV by catch-vessel phenomenon, biventricular hypertrophy, clinical diagnosis without even auscultation. You can clearly say it is a classic feature of VSD with Eisenmenger. Clubbed fingers, cyanosis, desaturation. This will be a classic feature of it.
Thank you, sir. Thank you so much.
Thanks, madam.
ரொம்ப சிம்பிளா ரொம்ப நல்லா புரிஞ்சுது சார். Thank you so much.
Thank you, madam. நீங்களாம் professor, madam. Thank you. You have taught so many students in your life. Thank you, madam.
Thank you for that also. Good night, sir.
Right. If no other questions, shall we close it? Find it. Thank you. Thank you very much.
Thank you, sir. Thank you very much.